chat as well, so that if you have other colleagues, fellows, students, residents, supporters, whoever who might be interested in listening to this webinar, they have an opportunity to do that. I'm really excited today because our topic is going to be the ethics issues around maternal and child health during this period of the COVID-19 pandemic. This is a really central and important issue for public health in general. Maternal and child health is fundamental to both the practice and research elements of public health around the world. And particularly right now, in the middle of this pandemic, there are great concerns that the general function of maternal health is being affected. In other words, we foresee both direct and indirect implications of the pandemic on pregnancy, childbirth, early child health, later child health, and very importantly, maternal and reproductive health. And I'm really excited also because two wonderful colleagues are joining who are not only experts in their fields, but also have a very broad spectrum viewpoint about this topic. I have Dr. Lena Wen and Dr. Amita Vyas with me. What I'm going to do is request each one of them to actually make an opening comment and for a few minutes from their perspectives about their ideas around maternal child health, COVID-19, and some of the operational and importantly ethics issues that they would like to propose and discuss. Following these opening comments, I'm going to open up for question answers. So while they're talking, while they're speaking, if you have issues, questions, reflections, please use the chat board. Myself, as well as my colleagues, Hina and Michelle will be monitoring that. And I don't know if we will have the time to get to every comment, but we will try our level best to make sure that we have an interactive dialogue going on here. So let me start with my first guest. Dr. Lena Wen, I believe, has joined us. And Dr. Wen is an emergency physician and a visiting professor of health policy and management here at George Washington University, particularly our school, Wilson Institute School of Public Health. She's also a distinguished fellow at the Fitzhugh-Mullen Institute for Health Workforce Equity. Of course, Wen is a very frequent visitor of the major news and media channels in this country, and I'm sure you've seen her in CNN and MSNBC and other news channels. Most importantly for me, because I live in Baltimore, she was Baltimore's health commissioner, and where she did an amazing job at looking at the health conditions frequenting this issue. Dr. Wen has been named one of modern healthcare's top 50 physician executives and Time Magazine's 100 most influential people as well. So Dr. Wen, we'd love to hear from you about your perspectives and your ideas and even your personal experiences around maternal and child health during this time of COVID-19.
Absolutely. Thank you very much, Dean Hyder. Can you all hear and see me?
Yes. Yes.
All right, wonderful, thank you. I'm as much as we've been all using Zoom recently, I know that technology can always go wrong, and so apologies in advance if you see my toddler, for example, bursting into this room. But I want to thank Dean Hyder again for organizing this, and Hina and Michelle also for your team for your hard work as well. And I appreciate the opportunity to be here with all of you today for this important seminar. So I wanted to share two aspects of this. One is the professional side of what is going on with COVID and how this is affecting maternal and child health, my thoughts about this as well. And then I also wanted to share a personal reflection about what this time means to me as well, as in addition to everything that that Dean Hyder was very kind to share about my bio, I also am a new mother. I have a nearly 3-year-old, but I also have an 8-week-old daughter who was born in the middle of this pandemic. So have experienced everything that we're talking about in a very different way as well. So, you know, I was just on CNN and MSNBC this morning talking about what reopening has looked like. I mean, there are a few issues I'm sure that you all have been living through too, this kind of false dichotomy that's been set up between public health and the economy. And I think we're also living in a time of misinformation too, where, I mean, even the idea of wearing a mask somehow has become a political symbol instead of the public health imperative that it is. And I've been very concerned about what people have been interpreting about this idea of reopening our economy, that reopening somehow has been equated with everything is fine, so go back to your normal lives. And I say all of this in the context of maternal and child health because we know that those who are affected the most by whatever it is that's going on in our society are those who already face the greatest disparities and the greatest vulnerabilities. And so we know that there are already profound disparities in maternal and child health. These disparities are unmasked by the COVID-19 pandemic, that it's essential workers who have been on the front lines, who don't have the privilege of doing social distancing, who have gotten sick and their families have gotten sick. And of course, those individuals who already have underlying medical problems are more susceptible to the severe effects of COVID as well. So I fear that now that we are reopening, and it seems like haphazardly in some cases, without having the decline of cases across the states as we should, without having the infrastructure, the testing, tracing, isolation infrastructure already in place, if that's the case, then those who are going to be impacted the most are those who have the least defenses and the least ability to access healthcare, who have the greatest disparities to begin with. So I think on that professional front, if you will, I have a lot of concerns about where we are as a country, about what reopening prematurely means. And unfortunately, with the politicization of healthcare and science, we're seeing again unnecessary deaths. Frankly, that's going to occur. And so I hope that we'll get to talk a bit about the disparities that are existing and how they are unmasked by the COVID-19 crisis and what those ethical concerns might mean. But I wanted to specifically share too about my personal experience, because if it's anything that we've seen in this crisis, it's that healthcare continues to happen. That, of course, COVID-19 has become the dominant public health issue of our time. But just because it has, it does not mean that the rest of healthcare is not also occurring as well. So I became pregnant at a time when, of course, nobody had heard of COVID before. It was not part of my thinking in any way. I, of course, gave birth in the middle of this pandemic, and I gave birth at the same hospital that I had my son 2.5 years ago. And yet my experience was totally different, despite having the same OB and the same care team. Week after week, I saw guidelines change. First, my hospital was one that welcomed the entire family to be there in the labor and delivery floor. Of course, then we saw restrictions and guidelines change. From 1 week to another, I couldn't have a visitor come with me for my prenatal appointments. Another week, I was encouraged to switch as many of my appointments as I could to telemedicine. Another week, the entire waiting room was emptied out. And then, of course, during that time, I also saw in New York and in other places, there were even instances of women who were not allowed to bring their partners or anyone with them during labor and delivery itself. That procedure, of course, in New York was quickly overturned, but there were women who gave birth without having their partners present during that labor and delivery process. On the day that I ended up giving birth, I found out that a doctor and a nurse had just been diagnosed as being positive for COVID, and a number of other staff were out on quarantine. So I was actually supposed to be there for an induction and was told that there was no space for me that night and to come back the next day because so many staff were out on quarantine. There was a new policy also about having staff wear masks at all times while they're interacting with patients. And I remember talking to my doctor and nurse. They were issued one mask, one surgical mask per week that had to last them the entire week. And they were on day 3 or 4 of wearing that mask. And the mask had gotten so fuzzy that they didn't know if it could last them the entire time. And I could see them visibly itching underneath their mask. It was that uncomfortable. I mean, I mention all of this because we're living in such different times. And I think people have all kinds of concerns. I mean, I know that I worried when I went in as a patient about whether my providers could be asymptomatic carriers and give COVID to me. I think they worry too about whether I could be the asymptomatic carrier. I know that my nurse, during delivery itself, I couldn't hold her hand. And I was afraid that when she came close to me, that maybe I could expel droplets that could get her sick. I mean, these are very different types of concerns than we've ever had, especially during this type of time in our history. My nurse and I also joked that maybe at some point I would see her in the grocery store and she would come up and ask me how my baby's doing and want to give me a hug. And I would be thinking, who is this person? Because I never saw her without her mask. And what a time it is for someone to be with me during the most vulnerable time in my life and to not even be able to see their face. I actually gave a talk to some of my emergency medicine colleagues a few weeks ago, and we were all commenting on how the simple acts that we're doing now, we never thought would be imaginable. The idea that we are holding up a phone to a dying patient who cannot see their loved one in person, and they have to say goodbye over FaceTime. I mean, things like that that we just never thought that we would be dealing with as providers. Even the idea of rationing personal protective equipment, we never thought that we would be having at this time. And I think that it just brings up a whole new sets of challenges, to be sure. But I think it also calls into question who we are and what our shared humanity really means to all of us at this time. And so I do believe that this is a time when we're all in this together, that there is a chance for us to look at the challenges that we're facing and delve further into them, to call into question our shared humanity, to address these underlying disparities that have haunted us for so long. And I hope that we will get to some of these and other questions during our conversation today. Thank you.
Thank you very much, Dr. Wen. This is a remarkable, first of all, for your insights, both as an emergency doc, as well as someone who's been in the health policy field for so long, both at city, county, state, and now national levels. I think your concern around everything from the politicization of public health measures to concerns around disparities, which are major equity issues for us, both in this country and around the world. And then thank you very much for sharing your personal journey, and congratulations on your baby. And I'm so thankful that both you and your family are doing well. And we'll come back to some of these issues in due course. I'm also very excited to now welcome my colleague, Dr. Amita Vyas. Dr. Vyas is a professor here at the Milken Institute School of Public Health at George Washington University. She got her master's and doctoral degrees at Johns Hopkins Bloomberg School of Public Health, and really is an expert on women's and adolescents issue, both here in the United States as well as globally. She's also a non-resident fellow at the South Asia Center at the Atlantic Council and editor-in-chief of the journal Women's Health Issues. So you may have seen her either through those multiple affiliations. But I think what's really important is that Amita has really been leading the concern around maternal and child health issues in public health. And I'm very excited that she can talk a little bit about her perspectives during this pandemic. So over to you, Amita, and I think you may have a few slides. I think Michelle will put them on as you come on board. Thank you very much, Amita.
Thank you. Thank you, Dean Hyder. It's a pleasure to be here. And to you, Dr. Wen, congratulations on your new baby. I'm sure this is a very exciting time for you and your entire family, and glad to hear that everybody is doing well. So of course, as a professor, I've got to have a few slides. I thought it would be a little bit easier to go through what is unfortunately so many issues that are facing women and girls through this COVID-19 pandemic. Michelle, if you could switch to the next slide. So as Dr. Wen mentioned, you know, COVID-19 is not an equal opportunity pandemic. We know day by day that women and girls are disproportionately affected by the pandemic. And these disparities stem from both public health strategies that have been put into place to mitigate the virus, such as shuttering in place orders and pausing the economies, as well as disparities from neglecting key maternal and child health services and reproductive health services, as our health workforce has really been focused on this virus. There are several factors unique to women and girls, and I've sort of outlined a few of them here, and I'll go through them quickly so that we can move on to our discussion. But you know, women are really on the front lines of this pandemic. 70% of all hospital jobs here in the United States are held by women, and that is everything from physicians and providers, nurses, to employees who are taking care of the laundry and janitorial services. And globally, 70% of all healthcare workers are women. So again, they are physicians, our nurses, our midwives, and they are on the front lines of this epidemic, and we know what those risks are, particularly, as Dr. Wen had said, when we've seen surges in hospitals and limited PPE. And again, I think what's really important to remember as we look at all of these things is that they're not just happening here in the United States, and they're not just happening in low and middle income countries, they're happening in both places. We also know that women are caregivers for both young and old. And when we look globally, again, particularly in low and middle income countries, these responsibilities also extend to adolescent girls. Adolescent girls who have always been sort of forced to take on household work and chores, and it's likely that they're taking on more of these responsibilities today. When we think about unpaid work here in the United States, women spend 37% more time on unpaid care than men. And globally, women perform 72% of total hours of unpaid care work. Clearly, this is important work. It's essential to taking care of our families and societies. And now, under this global pandemic, we've got women who are home caring for children with the added burden of homeschooling, possibly caring for sick family members and aging parents. And women, again, both in the United States as well as globally, are responsible most often for providing meals. And this has become even more challenging today as we think about levels of hunger and food insecurity. So all of these sort of added pressures to what I call sort of the highly burdened gender roles that women take on are likely to result in increased stress levels, anxiety, emotional distress, and of course, physical health as well. And we know that women and adolescent girls are often living in dangerous homes. So as social distancing and stay-at-home orders were put into place, we know that women were isolated and trapped in their homes. Millions of women couldn't access domestic violence hotlines or counseling services, which are often a lifeline for them, and really left them little opportunity to access any kind of help and services. Unfortunately, we learned this before in 2015 during the Ebola outbreak. We saw that adolescent girls actually experienced higher rates of sexual abuse and teen pregnancy. So the violence that both girls and women are facing, again, it's not just here in the United States, but really we've seen the escalation of domestic violence across all countries that have been facing the COVID-19 epidemic. When we think globally about girls' education, we have made great strides, right? Outstanding gains. We've got more girls going to school, particularly secondary school, than ever before. But again, as we saw in the 2015 Ebola crisis in West Africa, girls were the most vulnerable when schools shut down. And so for many of us who work in the field around adolescent girls and education, we are very concerned that when schools reopen, particularly in low and middle income countries, many adolescent girls will not be going back to school. They may have to take on, again, increased family responsibilities. They might have to actually get outside work in the informal sector, or they might be married off too soon and also have to experience early childbearing. And then finally, here in the US, as well as again around the world, we have significant economic consequences. And we see that this is disproportionately affecting women. People have now coined this economic recession the she-cession. And I don't think that that can really be overstated. In the United States, 60% of the job loss here has been among women, women particularly who work in hospitality industries and other female-dominated industries. They were the first to lose their jobs. I think compounding that, we know that women are also single mothers. In fact, there are 5 times more single mothers here in the US than there are single fathers. And when we look across the globe, we know that 70% of women are actually employed in the informal economy. And again, those were the first jobs to be lost when the COVID-19 epidemic hit and shutdown orders were put into place. Michelle, can you put the next slide? So specific to maternal and child health, and I think Dr. Wen touched on a lot of these issues, we've faced significant racial disparities here in the United States. We have one of the highest maternal death rates of all industrialized countries, even right here in our own backyard in the nation's capital. It's one of the highest in the entire country, and it's 3 to 4 times greater among African American women. We know that women, both in the United States and globally, who are most at risk are often not accessing antenatal care until their second or third trimester. And we see that through this COVID epidemic, that's probably most likely increased, again, for all of the reasons that Dr. Wen went through in terms of her own experience in terms of healthcare appointments. And globally, we also know that it is so paramount to have skilled birth attendants to really mitigate maternal and infant deaths. And whether or not women can actually access skilled birth attendants during these lockdowns is something that we are also very, very worried about. Another example that we learned from the Ebola outbreak was that in 2015, during the outbreak, maternal and child health services plummeted during that outbreak. And when all was said and done, maternal and newborn deaths actually outnumbered Ebola deaths. So we know this is something that we've really got to pay attention to. As I said, we've seen escalations in gender-based violence, and that violence does not end when women become pregnant. So we see even greater life-threatening risk to both mothers and their infants. And of course, with the lockdown, sort of a lack of social support, both from friends and family, but also from community-based organizations and nonprofits who provide life-saving support, whether it's around breastfeeding, postpartum health and depression, nutrition, and many of these organizations are struggling to reach the women that they need to reach and struggling to really stay in operations. And of course, sexual and reproductive health services. This is very difficult for women and adolescent girls to access, again, both here in the United States and around the world. These are important to sort of long-term health and well-being of adolescent girls and women, and they are unable to access those services. And of course, we could probably have a whole new webinar focused on infants and children. So I won't go into too much detail there, except to say that there is great concern that infants and children are not getting the immunizations they need to be getting. Of course, the food insecurity and hunger that we've seen both here in the US and in other places, mental health, and abuse and violence. We're seeing an increase and a real uptick in the number of children showing up to emergency rooms here in the United States as victims of abuse and violence. Michelle, could you just switch the slide? I'm hoping we can talk more about solutions. I feel like I gave you all a lot of sort of doom and gloom. Although I said that, I think that there are solutions, and as we are gearing up for, as Dr. Wen said, reopening our economies, reopening countries, and possibly getting ready for another surge in the fall, I think that there are things that we can do. I've been lucky to be participating in local health department efforts around case investigations and contact tracing. When we're doing those case investigations and contact tracing, we're asking women lots of questions, lots of details about who they've been with, who they've seen in the last 48 hours, what symptoms have they had, where have they traveled. There's no reason why we shouldn't be asking them if they feel safe in their homes and what other kinds of health services do they need and social support. We need to think about policies. We really need national leadership, political leadership to make sure that telehealth appointments for women during the antenatal period, that those will be covered by insurance. We need paid leave and equal pay for women working in all different sectors. Of course, we need to be thinking about social support and then access to sexual reproductive health and maternal and child health services. Michelle, the last slide. So I'm hoping that we will emerge from the COVID-19 pandemic a more just, fair, and equal world, but I do worry that everything that we're seeing right now could really reverse the gains. They've been small, but still we have made gains in terms of gender equality and addressing the issues that girls and women have been facing. Thank you.
Thank you very much, Dr. Vyas. That was a wonderful review of the larger reproductive, maternal, child health situation. Much appreciated your reminders about the role that women play, first of all, generally in healthcare, both in the US and globally, but also specific to issues around, you raised domestic violence, the impact on schooling, on education, and this wonderful terminology of she-cession as opposed to recession, and that impact. And I will come back to you. So, ladies and gentlemen, this is a time where if you can use the chat board to put your questions, your reflections, your commentaries, we'll try and get to you. You've heard from both our speakers right now. What we are interested is having a little bit of a dialogue. I'm going to kickstart that dialogue in a second. I've already noted a couple of comments and questions already on the chat board, but go ahead, put your perspectives. You may be from a different country, you might be from a different part of the US, and you might be thinking differently. What are the issues that you would like our panelists to talk about? Dr. Wen, I wanted to come back to you first and talk a little bit about this notion of the process of labor and delivery, where going from a situation where you could have multiple family members of your choice to a situation where you may not be able to have anyone. Does this posit issues of autonomy, right? So we have the autonomy of the woman deciding who should be there, and the what we call paternalistic attitude of the healthcare system or the public health system dictating. How do you see that tension? How did you yourself experiencing that? Talk to us a little bit about it.
Yeah, that's such a great question. I appreciate your asking. First, to acknowledge that the labor and delivery time and just pregnancy overall is a time of great uncertainty and anxiety. I mean, I remember the first time that I was pregnant, both of my pregnancies were high-risk pregnancies. And the first time I had a lot of anxiety just around what is labor and delivery going to be like, right? Having not done it before until you do it. How do you know? I didn't know about what breastfeeding was going to be like. And I didn't know about childcare and how we would find childcare. I mean, already there were so many concerns. And this time, of course, there was a whole different level of concern of, is my husband going to be there with me? Am I going to get infected? I mean, there was a point where my newborn was going to be taken away for hearing checks and immunizations and other things. And I couldn't go. My husband also could not go with our newborn. And I mean, there's that other level of anxiety too. And so, so I see your point. I mean, I think a lot of people, myself included, would have been extremely anxious, or maybe I'll say it differently. I don't even know how I would have felt if I were told that my husband could not be with me while I was in the hospital. As we entered from the parking lot, we had our temperature checked and everything else. But, if he actually were sick and had a temperature, of course, I would understand why he couldn't go. But just the visceral thought of my husband couldn't be with me and nobody could be with me during this time of great vulnerability would be really, it would be, I think, really hard to swallow. But at the same time, there are two other factors at hand too. One is that I thought about all these other patients too, these patients who are dying. Or you come into the ER, I'm an emergency physician, you come into the ER and you're very ill, maybe for something non-COVID related, you have a stroke, or you have severe chest pain, and you're told that you have to go to the cath lab, or you're told that you have to go for emergency surgery, and you still can't have somebody with you either. I mean, I think that there is something kind of different about the beginning of life and pregnancy and childbirth, but I think about all these other patients at another extremely vulnerable time of their lives who also cannot have someone with them. And I think, well, maybe we're not so special, right? That we are all going through this together. So I think that's one point. And I think the other point too is the reason this guideline came into practice in the first place was in New York. As I understand, there was a case of a partner who did have symptoms, who did not disclose the symptoms, and who went in and potentially infected staff and other patients and other newborns who are extremely vulnerable. And I do think that individual actions also affect policy too, that when you have individuals who may act selfishly, for lack of better words, that also ends up affecting policy for everybody else too. And so I would like to think, I wasn't put into this position, but I would like to think that if I had to face this situation of my husband not being with me, I hope that I would have been able to call upon some greater grace than I might otherwise have, and realize that as much as I would want this for myself, that there is a greater good that we're doing these sacrifices for as well.
No, thank you very much. I think this whole notion of optimizing the good for large numbers of people, of course, drives many, many public health actions. Dr. Vyas, in some ways, you also spoke about that. As you know, the Lancet has published a paper that says, as a result of COVID-19, maternal healthcare services and child health services might be affected. And their predictions, their best predictions were like over 250,000 child deaths and something like over 12,000 maternal deaths. So to your point, how do we do this risk-benefit ratio in ethical terms, the beneficence of our actions and do no harm of our actions? Could you talk to us a little bit about that?
Yeah, that's a hard question. I agree with everything that Dr. Wen said. It really is upon all of us to not just protect ourselves, but to protect our families, our communities, and the larger society. And we all do need to make some sacrifices. I think my hope is that what we're learning, right, as we've said, is that this has really sort of shown a light on the disparities and in the gaps and holes and problems with our healthcare system. And so what we need to be really doing is saying, okay, well, this virus isn't going anywhere anytime soon, right? Governments are going to start to open up. We might end up in a lockdown, who knows, many months from now if we were to surge and have another wave again. But we need to be prepared for it this time. I don't think it's sort of an all or nothing. You know, you either get your healthcare services or you're in lockdown. It's not an all or nothing. I think we need to be able to provide telehealth medicine. It's not always ideal, but we do need to figure out how we can provide that telehealth medicine. When I think about countries that I've worked in, like countries in India, where community health workers are key to maternal and child health services, we need to start training them now on new innovations and their ability to hopefully provide telehealth, you know, even to those who are most poor and most vulnerable amongst us. So yeah, I mean, I do think that these projections are real. I think that we weren't prepared for it, but it really has shown a light on this very broken healthcare system. That's here in the US and as well as places around the world. So we need to very quickly innovate to get ready for what's to come.
And Dr. West, just on that point, so one of our participants is very concerned about the fact that most community health workers around large parts of Asia, Sub-Saharan Africa are women. And you mentioned this as well. And so in situations where those services are not going to be provided, isn't there like a double effect here, because the providers are women and the recipients are supposed to be women as well for a large majority of those services? So that's almost like a double whammy here.
Yeah, absolutely. And, you know, in some parts, again, in India, where I've worked quite a bit, you know, we do see community organizations and NGOs that are still trying to deploy some community health workers out there. So again, they're part of that 70% of the healthcare workforce. So they are taking risks and they are trying to go out and provide some services, again, to a limited few. But again, you know, women are kind of getting it on all ends, women as healthcare workers as well as recipients of these services. And that's why I think we do need to come up and develop sort of new innovations to be able to provide services. I mean, this is a hard one, right? I mean, it's sort of people's individual rights and wanting to provide care, exactly as you said, do no harm. But, you know, there's also do no harm in staying home, right? And not going out.
That's correct. That's correct. So Dr. Wen, you know, one of the things, and I've seen you on media appearances as well, really thinking about and saying we must wait for clinical trials. We must wait for the result of studies. We must be evidence driven. And as you know, even under normal times, there has been debates about the value of having pregnant women or recently delivered mothers as human subjects research in those types of studies. Do you think there are some issues that such populations should think about before they themselves either volunteer for studies or where the principal investigator should enroll them? What are the pros and cons of engaging either pregnant women or new mothers in such trials?
Well, that's such a great question. And I have to admit that I haven't thought much about it. And so would also love to hear your answer and Dr. Bias's, perhaps your thoughts about this as well. I mean, you know, just thinking in general about COVID-19 and pregnancy, there is so much that is not known about it. I mean, I'm asked a lot of questions as a physician from my patients, but also as a new mother myself about you know, people being worried about what's the rate of miscarriage and what are the effects on the fetus and maternal fetal transmission. And it's very hard to give the answer of, we just don't know. And we're not going to know. I mean, how could we possibly know with a virus that's not yet 6 months old about the impact on the first trimester, right? We just don't know. And even the initial studies coming out, I think there is a lot of misinterpretation too, because studies are coming out before they're even peer reviewed. And then when they're coming out, sometimes they're understandably of small samples or they're anecdotal reports, but then a lot is read into them. Policies are even made that are changed as a result of these studies. And I think it also causes a lot of confusion. There were conflicting studies about whether there is maternal fetal transmission. I think there's still a huge amount that's unknown about the impact on pregnancy. And I think there are a lot of questions that are probably not going to be resolved either, because who is going to be doing this experiment, as you were saying, on pregnant women or of new moms or of infants, of newborns? So I think it does bring up a lot of questions that I'm not sure the answer to, because on the one hand, we do want to know, and as much as we can obtain from observational studies, from anecdotal reports, the better. But I think it remains an open question too about, once a vaccine is obtained, how do we know, for example, about safety, or if there are treatments that are there? I mean, I thought a lot about when I was pregnant, just because I'm an ER doc and we think about worst case scenarios all the time. I thought a lot about, what if I were diagnosed with COVID? I mean, there were reports at around the time that I was about to deliver, of critically ill women in their third trimester who had to deliver as a last ditch attempt to save their life. And I thought a lot about, well, what if that happened to me? I mean, we don't know about the impact of all these new medications that are not yet studied on anyone, much less on pregnant women. But what are the ethics too of administering these medications that are unknown? But when when there is no other hope, is there a benefit to administering these too? So I'm not sure that I have any answers, except a lot of questions that I will direct.
It's a great discussion. Dr. Vyas, do you have perspectives on this particular point?
Yeah, I think that that's a difficult one. And I think that, if we look through history, we have often faced this around vaccines and other clinical trials. I mean, the one thing that, and Dr. Wen, you probably know more about this than I do, but based on all of the sort of smaller observational studies that have come out, particularly from China and countries that were hit with COVID before us, there doesn't seem to be that transmission. And there seems to be little to no harm in terms of COVID during pregnancy and childbirth. So I think that that's sort of the good news. And maybe we can, we need to continue to monitor that. Again, I think it's really upon us in the scientific community to make sure that we continue to collect that data. I mean, I think overall, when we think about all of these issues related to women and girls that we've talked about, the key right now is that we're both addressing them, but that we're also collecting real-time data. And I think, yes, we need to be focused on COVID-19 mitigation, containment strategies, but we also really need to make sure that we're doing the studies right now in real time so that we eventually can have the answers to the questions that Dr. Wen put forth.
I think you both are right. I mean, there's no easy answer. I think one way of thinking about it is that the intervention that you're testing eventually needs to be implemented in certain populations. If you exclude a population from the testing, then how will you know that it's going to have a benefit in that population? And so the old example of the Framingham studies, which often were done on men, and then you learned a lot about cardiovascular diseases and tried to apply that to women. And I think a lot of groups, including bioethics centers, are very concerned that on the face of it, pregnant women being deemed a vulnerable population means that they are often excluded from the very studies that they need to be included in order to study their effects so that they can be used in the future. So it's one of those situations where I think we have to be very careful with, of course, informed consent and implications, but I think that does offer us at least some things to think about. Dr. Vyas, since I have you here, the real concerns you raised about domestic violence during this time, there are questions on the chat board that are asking about this. This seems to be a very negative, indirect effect of this. What should we do about this? What are the ethical concerns here? From the horrible situation of being trapped with the perpetrator to the other situation of not having places to go. Are there interventions we can think about? If you would care to comment on that.
Yeah, absolutely. And again, no easy answer. And it's something that I've thought a lot about, right? I mean, how do we reach women who are trapped in these homes? And I think, some of the things that struck me early on was that, we saw things like essential businesses that stayed open during the COVID epidemic, things like gun shops, for example, right? We saw that the sales of firearms increased exponentially right before all of the lockdowns and stay-at-home orders. We continue to see that alcohol and liquor stores are deemed essential in most states, right? And we saw increases in alcohol sales. All of these things are triggers, right? They're not causes per se, but they are triggers and they exacerbate domestic violence. So I think, we needed to really be thinking about how this is affecting women in violent homes, and should these be essential services? What can we do about that? But also, again, we need women's voices at the table as we're thinking about both mitigation, but going into our containment strategies. And as I mentioned earlier, the thing that's really sort of struck me going out and working in our local health departments, doing case investigations and contact tracing, is that I'm asking women lots and lots of questions. It would be very easy for me to ask them, do you feel safe at home? Right? And we need to put into place some of those sort of screening types of questions that would immediately trigger a set of community services that can go in and help women and their children. And we need to really be thinking about that as we, move on in this epidemic.
Yeah, very, very tough issues. A similar indirect effect, Dr. Wen, is great concerns around vaccination programs for children. Mothers are worried about taking their kids for vaccinations. Families are in suffering poverty, transportation issues, movement issues, clinics closing down. What's going to happen to the immunizable diseases in this country? Should we be ready for another influx of what we call vaccine preventable conditions, even the ones that we did have?
Oh my goodness, that would be so terrible, right? Considering that we've already had problems in this country with disinformation and the concerns around vaccines, which, by the way, I also fear are going to come up again now that we're talking about vaccines so much. And even the moniker of Operation Warp Speed, the idea of developing vaccines very quickly, it actually feeds into the anti-vaxxers movement, who think that somehow we're bypassing safety. There are these conspiracy theories about who's benefiting and big pharma benefiting. I mean, I'm already worried about that component of it. And then you add on top of it what you just said about the inadvertent effects, right? Not the misinformation, but the inadvertent effects of kids falling behind on their vaccination schedules, which I have to say is something that I'm worried about even for my own family, because my pediatrician's office, like so many others, have changed their protocols, rightfully so, right? They've changed their protocols to try to convert as much, as Dr. Vias was saying, to telemedicine visits. I mean, that's the right thing to do. But we were also encouraged for a time to put off our child visits. And again, this was kind of in the peak of the pandemic. So again, understandable as to why. But as a result, everybody has been shifted. Everybody has been falling behind. And I think a lot of parents continue, including myself, continue to just be wary of what happens. I mean, I'm bringing in my 8-week-old. It's time for her shots. I'm bringing her in next week for her vaccinations. And even though my doctor's office has taken many different precautions, including eliminating their waiting room, the waiting room is now the parking lot. So you get called up to the doctor's office from the parking lot. I mean, they've had extraordinary precautions, but I'm still worried. And I think that, and we are coming from such a position of privilege. We have a car, we don't worry about, we have jobs, we have that privilege. But as you said, I think there's so many other conditions of families now losing their livelihoods, and maybe getting vaccinations falls much further down on the list of priorities that you add on top of their existing disparities. And I do really worry about the conditions that are related to vaccine preventable illnesses, but also to so many other illnesses that are now going to be manifest, including something we have not yet talked much about, but about mental health issues that will be manifest in women. I mean, the postpartum period, already one of the most vulnerable times in people's lives, not having caregivers and families around. And now, on top of all the domestic violence and other issues raised, just existing loneliness, addiction, mental health concerns that I think will be brought out even further through this pandemic.
No, thank you very much. I think that is of great concern. Let's see how things will evolve. But I think public health systems in this country and globally need to prepare for that. So Dr. Vyas, a couple of things that struck me in some of the comments here. One is the role of telemedicine, of course, and the other is the role of home visits as opposed to the patient coming to a centralized facility. Both actually are quite well established in many low and middle income countries. Do you think there's here an opportunity for what unfortunately is often termed reverse learning, that is lessons that we learn from other countries to come back to the US? Do you think that is something even in the District of Columbia we could explore with? What are your thoughts on that?
Yeah, absolutely. And, if we were to look at, specifically around maternal and child health, actually home visitation programs is an evidence-based program for women and children. And so in many communities, that has been a very effective strategy. I think if we can think about how we can scale up those strategies around home visitation programs, extend that beyond sort of, just community health workers, but other kinds of providers as well, I think that could be a new innovation to scale up here, but also bringing that innovation, as you said, from low and middle income countries. I will say, I know Dr. Wen has shared some personal stories, but actually right before this webinar, 2 of my children had their pediatrician appointments via telehealth. And that was our first experience. And I thought, oh, this is great, right? We don't, I felt very good about it as a parent, as a mom, that we weren't going to take the risk of going into the pediatrician's office. But I must say, and again, we come from a place of privilege. I saw so many things that were sort of wrong with that system. My children, I was in the room with my children. One's a pre-adolescent, the other's an adolescent. There was really no opportunity for the provider to ask sensitive questions of the adolescent. We know that that's a time of high-risk behaviors. It's also, a moment of being able to screen for violence. And so, of course, as a public health professional, I was thinking about all of those things, that it provided a little bit, but certainly not a lot. And both of my children needed a set of immunizations that they won't be getting now for months. They were told, well, you can come back in September. So, I don't think that it's sort of the end all be all solution, but I think that it is one step to sort of keep in touch with our healthcare providers. But as Dr. Wen said, a lot of healthcare settings and systems, as they're opening up, are putting a lot of precautions into place. And so it is my hope that people will be able to also go in for their visits.
Thank you, Dr. Vyas. Dr. Wen, you mentioned misinformation. I didn't want to let that go because, as you know, in this country, there's been a lot of concern around the origin of COVID, how it's being spread, how it can be contained. And globally, as I talk to colleagues around the world, there are conspiracy theories about where COVID emerged and who is perpetrating COVID. There are conspiracy theories about the World Health Organization as well, and its role and it dominates. So how do you think, in terms of justice and fairness, the public health community can really confront this? What are some of the ways that you've been discussing this with others? And insights from you would be very helpful for us.
I was thinking about all the different voices that we're now seeing all over the news on for public health experts and my colleagues and your colleagues and all of us. I mean, it's been great actually to every time I turn the news, there's someone that I know who I trained with or who I've worked with in some capacity who's now speaking on these public health issues. And I think that's wonderful. But why are we all speaking out now? It's because we have not seen consistent scientific messaging coming from the Trump administration, frankly. And I think the members of the administration, the scientific experts in the administration, have consistently been silenced or openly contradicted. And I think they welcome all these public health voices speaking up because they cannot. We can say what they cannot say because they are walking this very fine line working for President Trump and the administration, where they cannot contradict what President Trump is saying. And so they need the rest of us to speak up. And I think that voice, our voice speaking with science and reason and evidence and data, not speaking with politics, not speaking with partisanship and any of those goals. I mean, we have nothing we have no interest other than the best interest of the people, right? I mean, this is our only interest. And I think that kind of voice right now is so important. Now, I do think it's unfortunate that we have to do this. Ideally, the last time that we heard from the CDC was back in early March. I want to be having daily briefings led by the CDC every day. I mean, the CDC is admired all around the world. As reopening is happening, why are we not hearing from the CDC about the best guidelines that we should be implementing? Why are we only guessing? I mean, CDC guidelines were released somehow on the website, and it took days for people to even uncover these guidelines. And it was released basically in the dark of the night. Why is that happening? And so I think in the absence of a strong scientific voice coming from the federal government, and often, the voices that are going on even perpetuate prejudice and racism and unscientific thoughts. I mean, I was just asked over text, a text message that just came through as we're doing this, to respond to how President Trump is mocking former Vice President Biden for wearing a mask. I mean, why are we even responding to this kind of thing about, where something that's about protecting others from a virus, from a highly contagious virus, has somehow gotten politicized? I mean, and I'm not, trying to put politics in this. I'm just saying, since this is the world that we're in, our voice speaking up needs to be even more important than ever.
No, thank you very much. That perspective is very important. And fighting misinformation has become even more and more important. In fact, at George Washington University, we have a whole institute now that is working to see how bots are patrolling Twitter and social media and feeding off this misinformation. And this is a hugely ethical issue as well, because we are talking about trust. Do people trust society, societal trust in science and leadership? So Dr. Vyas, thinking about leadership, a couple of comments on have raised the issue that you briefly mentioned in your talk about gender, and how maybe the problem, and Dr. Wen's example of Biden versus Trump is man versus man, but you have countries like New Zealand, like Germany, being led by women who've done so much better. And we are repeatedly we're studying these examples of much better leadership. So talk to us a little bit about gender, and particularly in terms of national or regional leadership there.
Yeah, absolutely. I mean, I don't think it's any secret that this administration hasn't done well by women, and has in many ways perpetuated the gender disparities that we've seen, the misogyny, the discussions around violence against girls and women. So yeah, absolutely. I think it's a great pride for women that we see countries who are being led by women, and we see that there are almost no cases or few cases in those countries. And so what was the difference? Absolutely, we need more women in leadership positions. Yes, we are going into the election with 2 men. It is most likely, I'm sure it is very likely, we will have at least 1 female vice presidential candidate there, but we need more women at the table, not just at national levels, but also at local levels as well. We need female leadership within our local health departments. Again, as we're thinking about sort of the work that local health departments are going to be doing in this next containment phase, we need women at the table to talk about the issues that women are facing, their need for social support, their need to, be able to access resources. And I would also say, one of the things that really struck me early on in the pandemic is that, everybody was into the 24/7 news cycle. And of course, all of the news stories were about the number of hospitalizations and the number of new cases. We saw little to no stories around the issues that we're talking about here today. And so, of course, we need national leadership on that. As part of sort of what our national response is to COVID. But I think that that's also, as Dr. Wen said, on us as public health professionals to make sure that we're getting this information out there. If there are ways that we can help women who are trapped in their homes, if there is information that we can give to mothers and fathers about their well child visits and the importance of immunizations, we need to be doing that too. I think even more so today, we need to be using our news cycles to reach directly to the American public, to tell them, to give them the right information. Because right now, that is something that's significantly lacking in our national leadership.
I think that is fundamental, isn't it? Because people sometimes forget that the conversation is often controlled by those who are at the table. And those who are at the table belong to particular ethnicities, particular genders, particular race. And so it is important. Sometimes people say, oh no, you're being concerned about semantics and numbers. No, actually the conversation changes, the content changes, decisions change. And so I think we've seen the examples of Germany and New Zealand and Taiwan and so on. And also we've seen the differences from where leadership comes from, how evidence-based they have been in their own practice prior to COVID-19, and how to move forward. Ladies and gentlemen, we've really tried to cover as many topics as we can, but we are running up against time. For example, some of the issues that we've not touched upon is one of our colleagues from Africa has just put on the chat board about concerns of extremely vulnerable populations like refugees. We know the refugee populations in sub-Saharan Africa. We know the Rohingya camps actually around Cox's Bazar in Bangladesh and the issues of COVID-19 there. Can you imagine maternal and child healthcare delivery right now in those particular conditions? These are incredibly difficult issues of justice and fairness that we've not had the opportunity to talk about. Some of our participants have talked about, wanted to talk about things like when you separate mother and child as a result of COVID positive maternal tests, what does that mean? Because these guidelines were in place in some institutions. The United Nations Population Fund, UNFPA, which really deals with the wide spectrum of maternal and child care issues, has released a few guidelines around COVID-19. And in general, I can summarize them by saying that they really want countries and governments to support, first of all, those who provide maternal and child health care, to protect those providers. Number two, to ensure that there is safe and respectful maternity care during these times. And very importantly, to see if priority can be given to what they call maternal health systems where mothers and children often visit, both treatment and prevention. So with the recognition that we've not been able to cover all topics, please note that we really wanted to thank both our colleagues, Dr. Wen and Dr. Vyas, for coming here, for sharing their perspectives. And I want to thank all participants as well, particularly those who are joining from other time zones and have kept up to be with us today. Thank you so much. Please note our next webinar will be 2 Tuesdays from now on the 9th of June. We hope to cover issues around research and ethics during COVID-19. So in fact, we'll build on some of the questions that have been raised. I'll have 2 other fantastic panelists joining me at that time. Once again, thank you, Dr. Vyas and Dr. Wen, for sparing an hour of your busy time. Very much appreciated your perspectives. And I'm so happy that I was the minority gender on this panel. Thanks, everyone. A reminder to any student who would like their forms to be signed, please contact Michelle. And in the next 48 hours, you will see a recording of this on the YouTube. We'll make sure that we have it on the website as well. Thank you very much. Take care and be safe in your home locations. Bye-bye.
Thank you.